Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a pharmacist, and I'm here to bring you quality information regarding medications and health-related topics. If you've enjoyed my last couple of videos, consider subscribing. With that being said, let me just go ahead and start. Phentermine topiramate is a fixed-dose combination of two drug classes, the sympathomimetic amine phentermine and the anticonvulsant topiramate. In my last video, I focused on sympathomimetic amine anorexiants, which included phentermine, so today I'll focus on topiramate as part of this drug combination. I'll refer to the drug combination by its brand name, which is Qsymia. While creating this video, I came across a couple of different pronunciations for topiramate. LexiDrug pronounces it as topiramate. Make of that information what you desire, but I'll pronounce it as topiramate because that's what I'm accustomed to hearing. Topiramate is a broad-spectrum anti-seizure medication, and its mechanism of action is not completely understood. Let's split up its mechanism of action into four known unique actions. Number one is blocking of voltage-dependent sodium channels. Number two is enhancing the activity of GABA in certain GABA-A receptors. Number three is antagonizing AMPA and kainate receptors. And number four is inhibition of carbonic anhydrase enzymes 2 and 4. Since this is an obesity-related video, I'll keep the focus on the key mechanisms that play a role in weight loss, which is its effect on GABA receptors. GABA receptors are inhibitory receptors in the central nervous system. The anti-epileptic actions occur when topiramate binds allosterically to GABA-A receptors, which are chloride ion channels. This causes the GABA-A receptor to become more responsive to GABA when it binds to these receptors. This allows more negatively charged chloride ions to flow into the neuron, which creates a hyperpolarized environment in the cell, which leads to stronger inhibition, meaning less signaling occurs between neurons, and we end up with reduced neuronal excitability. Topiramate's appetite-suppressing effects occur through a different mechanism than its GABA-A effects. Based off transgenic mouse data, topiramate appears to increase presynaptic GABA release in hypothalamic circuits, which can suppress orexigenic neuropeptide Y, a Goody-related peptide neurons, in the arcade nucleus, likely via GABA-B receptors and potassium efflux, which causes hyperpolarization and inhibition of the cell. This reduces neuronal excitability, which reduces appetite and food intake. I want to point out that GABA-B receptors are not chloride channels, but are G protein coupled receptors. Qsymia demonstrated a 5.1% to 10.9% weight reduction at 1 year, with sustained weight loss of 9.3% to 10.5% at 2 years in the sequel extension study. These clinical trials indicate Qsymia shows a dose-dependent weight loss. Since I covered phentermine in my last video, I'll focus on topiramate's adverse effects, which can include CNS and cognitive effects, metabolic acidosis, nephrolithiasis, ocular effects, oligohydrosis, and suicidal ideation. The contraindications include those for phentermine, along with significant drug interactions and pregnancy. The warnings for topiramate include hepatic and renal impairment, dermatological effects, hypokalemia, and some formulations contain tartrazine. Qsymia is approved for chronic weight management. Qsymia is available in 4 fixed dose strengths, and the starting dose is 3.75 milligrams of phentermine / 23 milligrams of topiramate extended release in the capsule formulation. Each subsequent strength is just a multiple of the original strength. The highest strength is 4 times the original strength, which is 50 milligrams / 92 milligrams. The medication is only taken once a day in the morning and should be titrated up. The starting dose is the 3.75 milligrams / 23 milligrams once a day in the morning by mouth for 14 days. If tolerated, it can be increased to 7.5 milligrams / 46 milligrams for 12 weeks. At this point, the weight loss should be evaluated. If the weight loss has not reached at least 3%, then the medication should be gradually tapered and discontinued or the dose increased. If the patient would like to increase the dose, then the 11.25 milligrams / 69 milligram strength is used for 14 days, followed by the 15 milligrams / 92 milligram strength for 12 weeks. After the 12-week period of the higher strength, we re-evaluate the baseline body weight reduction for at least 5%. If this goal has not been met, then the medication should be tapered off for a minimum of at least 1 week. For patients with creatinine clearance less than 50 based off the Cockcroft-Gault formula using actual body weight, then the maximum dose per day should not exceed the 7.5/46 milligram strength. However, with end-stage kidney disease, on dialysis, or patients with creatinine clearance less than 30, the use of the medication should be avoided. For patients with Child-Pugh Class B hepatic impairment, the maximum dose per day is 7.5/46. Avoid use in Class C. The medication is approved for children between 12 to 18, and for them, weight and BMI are used to assess dosing and adjustments. Topiramate has many drug interactions, including but not limited to alcohol, medications sensitive to alkalinization, CNS depressants, ulipristal, CYP3A4 substrates, and lamotrigine. Topiramate has a slew of effects on the central nervous system. The most common are dose-related effects, which include dizziness, drowsiness, and fatigue. It is shown to have both short-term and long-term cognitive dysfunction, even with doses below 100 milligrams per day. This can present itself as attention and memory impairment, and language problems such as poor verbal fluency, processing speed, reduced IQ, and especially word-finding difficulties. Topiramate can also cause psychiatric disturbances such as anxiety, depression, and mood disorder. Topiramate is also associated with paresthesia, with rates as high as 45% in some studies, although this is usually self-limiting and resolves over 2 to 3 months. Some of these side effects may occur early on in therapy, such as the sedative effects, but some of the psychiatric effects may take weeks to manifest. Risk factors include higher doses, high starting dose, or rapid titration, and patients with neuropsychiatric comorbidities. Most patients experience reversal of cognitive side effects within weeks to a few months after discontinuation of topiramate. Topiramate carries a class warning for increased risk for suicidal thoughts and behaviors seen with anti-epileptic medications. However, in a large cohort study of almost 300,000 treatment episodes of other anti-epileptics, such as gabapentin, lamotrigine, and oxcarbazepine, showed higher rates of suicidal acts relative to topiramate used as the reference agent. Topiramate is associated with hyperchloremic metabolic acidosis, not an ion gap, but is more common and severe in infants and children. This is due to impaired bicarbonate reabsorption in the proximal tubules and reduced hydrogen ion excretion in the distal tubules. This occurs because topiramate inhibits renal carbonic anhydrase. This occurs at any time and increases with higher dose. In adults, it's usually mild to moderate with a lowering of serum bicarbonate by 2 to 5 milliequivalents per liter on average. Persistent acidosis can contribute to nephrolithiasis, nephrocalcinosis, osteomalacia, and osteoporosis. Patients can be asymptomatic or present with tachypnea, confusion, and fatigue in more severe cases. Serum bicarbonate persistently lower than 20 milliequivalents per liter should warrant action from the provider. Topiramate is also associated with oligohydrosis. This presents itself as decreased sweating and above normal body temperature. Most cases reported is in children. The exact mechanism why this occurs is not fully understood and may be due to its carbonic anhydrase inhibitory effects, but animal studies appear to involve dysregulation of aquaporin 5 expression in sweat glands instead. Topiramate is associated with two major ocular adverse effects. They are acute myopia, which is nearsightedness, with secondary angle closure glaucoma, and the other one is visual field defects independent of elevated intraocular pressure. Acute myopia and secondary angle closure glaucoma is characterized by blurred vision and/or ocular pain, which usually occurs within 1 month of starting therapy with topiramate. This occurs because of superciliary effusion causing anterior displacement of the lens iris diaphragm. Basically, this means that fluid builds up behind the ciliary body, which eventually causes the lens and iris to shift forward. This then causes a shallower anterior chamber, which then narrows or closes the angle through which aqueous humor drains, increasing intraocular pressure, leading to acute myopia. Visual field defects can occur independent of elevated intraocular pressure. It's vital to counsel patients to report any visual changes promptly to their provider, and discontinuation of topiramate is important in managing potential complications with the eyes. Topiramate is associated with an increased risk of nephrolithiasis that is 2 to 4 times higher than the general population. This occurs because of topiramate's inhibition of carbonic anhydrase 2 and 4 in the proximal tubule, if you remember from earlier, leads to a loss of bicarbonate, raising urinary pH. The alkaline urine favors precipitation of calcium phosphate crystals. The risk of nephrolithiasis can be increased if the patient is also in a state of metabolic acidosis. This is because the body will increase citrate reabsorption through the kidneys, causing hypocitraturia, meaning there is less citrate in the urine to bind calcium. Leucemia is associated with congenital malformations such as oral and cleft palate and small for gestational age infants. A negative pregnancy test is recommended at baseline and monthly during treatment. Tartrazine is a dye that is found in some formulations of topiramate as an excipient. Approximately 3.8% of patients exposed to tartrazine have reported allergic reactions, including bronchial asthma. As a side note, individuals with an intolerance to aspirin have a higher likelihood of having a cross-reactivity reaction when exposed to tartrazine. The recommendation to titrate individuals off of Qsymia is to reduce the risk of seizures, even in patients without a history of seizures or epilepsy. Patients taking combined oral contraceptives and Qsymia may experience irregular bleeding due to pharmacokinetic interactions that decrease estrogen and increase progestin exposure. Qsymia reduced ethinylestradiol by about 16% and increased norethindrone by about 22% when administered with an oral contraceptive. This leads to destabilized endometrium, which can cause spotting. This interaction does not reduce contraceptive efficacy or require discontinuation of Qsymia. However, I want to make it clear that I am talking about Qsymia specifically. If we consider topiramate use on its own with higher doses, this information changes. The American College of Obstetricians and Gynecologists states that topiramate at doses less than 200 milligrams per day does not appear to significantly reduce effectiveness of oral contraceptives containing 35 micrograms of ethinylestradiol. However, doses greater than 200 milligrams per day may induce hepatic enzymes sufficiently to lower serum concentrations, which can increase the risk of contraceptive failure. As such, additional contraceptive precautions are recommended in these individuals, and changing to a 50 microgram ethinylestradiol dose is suggested. The interaction with alcohol and other central nervous system depressants when taken with topiramate is due to the increased central nervous system depression adverse effects such as drowsiness, dizziness, and cognitive dysfunction. Ulipristal prescribing information states co-administration of CYP3A4 inducers may result in impaired clinical effectiveness. Topiramate is a weak inducer of CYP3A4 and is listed as an example of a CYP3A4 inducer in ulipristal's prescribing information. Topiramate can affect the excretion of medications that are sensitive to alkalinization of the urine, such as amphetamines and methenamine as examples. In the case of amphetamines, it can reduce excretion in the urine by reducing their ionization, leading to increased reabsorption. In the case of methenamine, it can lead to decreased therapeutic effects because methenamine requires an acidic urinary pH to convert to formaldehyde, its active antimicrobial form. LexiDrug states that topiramate may increase arrhythmogenic effects of lamotrigine. The FDA had issued a warning about lamotrigine in patients with heart disease when combined with other sodium channel blockers. However, multiple large population-based studies and systemic reviews found no significant increases in ventricular arrhythmias, sudden cardiac death, or cardiac conduction disorders with lamotrigine use. There is currently no strong clinical data showing that combined lamotrigine and topiramate creates additive or synergistic arrhythmia risks beyond their individual risks, although caution is still appropriate in patients with structural heart disease. Okay, just like last time, I'll provide a set of 10 questions just for a little bit of fun. You can go ahead and pause the video before I go ahead and give you the answers. Question number 1. Topiramate contributes to weight loss primarily through effects on, and the answer is B. During Cousimmia titration, which clinical scenario most strongly indicates the need to discontinue or up-titrate therapy? The answer is B. Which renal hepatic status most warrants complete avoidance of Cousimmia? The answer is D. Which cognitive effect is most characteristic of topiramate compared to other anti-epileptic drugs? The answer is C. Topiramate-induced metabolic acidosis is best explained by which renal effect? The answer is B. Which urinary finding best predicts a patient's increased risk for topiramate-associated nephrolithiasis? The answer is B. The pathogenesis of topiramate-associated secondary ankylosing glaucoma most directly involves? The answer is C. A patient on Cousimmia and a combined oral contraceptive reports new onset spotting. Which explanation is most accurate? The answer is C. Which drug interaction with topiramate is most clinically significant and mechanistically correct? The answer is B. Which statement regarding the lamotrigine-topiramate combination is most evidence-based? The answer is C. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, consider subscribing and sharing my channel. If you guys do enjoy my videos, please consider leaving me a comment telling me what you think is good, what you think maybe needs a little bit of adjustment. Anyways, thank you and have a great day.